Good evening, everyone. My name is Julio Robledo, and I'm the Quality Improvement and Reform Project Officer at Brisbane North PHN. I would like to welcome you to tonight's session, Diabetes Management in General Practice. I would like to start this session with an acknowledgement to country. We acknowledge the traditional custodians across the land in which we are meeting today. We acknowledge the waterways, the land, the sky. We acknowledge their ancestors and elders and recognize those who continue to protect and promote Aboriginal and Torres Strait Islander cultures. We acknowledge the past and stand together for our future. Tonight, we have a really interesting session, and before we go into details, I would like to have some housekeeping rules. Everyone is going to be by default on mute and with the camera off. We do encourage you to use the Q&A section, the Q&A box at the bottom. If you have any questions throughout the session, we will try to get to them at the end. If we're not able to get to your particular question, we will send a follow-up email with the answers. If you require a certificate, please fill up the survey that is going to pop up at the end of the webinar. This is where you can fill up the details on the certificate. We would also like to encourage other participants who do not need a certificate of attendance to fill the survey. This is an excellent way for us to hear your voice, for us to understand what you need and try to fulfill those gaps that you are recognizing. This session will be recorded and all of this information will be sent to you in the next couple of weeks. I would like to introduce you to Jennifer Rausch. She is the lead for quality improvement and reform. And of course, someone who needs no introduction tonight with us is Jane Caligeras. Next one, please. Jane is the CDM Plus CEO. She has heaps of experience in this area, and she will be the speaker for you tonight. So please, Jane, take it away. Welcome tonight and welcome everyone.
Thanks, Julio. So tonight we're just going to kick straight in. We've got diabetes management. So what we're looking at tonight is identifying eligible patients for diabetes management. And we'll talk about that in two ways. The first one will be around health promotion, so ways that we can identify patients earlier and get them referred into some of the programs that are available. And then we're also going to look at the diabetes care plan process as well. And so too fast of a click. What we're going to go through is the practice team roles, and this is really, really important for all chronic disease management activities. Tonight we'll talk about it in the role of diabetes management. Identifying patients for recall. There's lots of different ways we can do this. So we're going to mention a few, some of the software, and we're going to talk about some of the CQI activities you can do around this whole process as well. And then creating and updating the care plans. So the case studies we're going to actually do a little bit differently tonight as we actually go through the whole presentation. So after each section, I've actually got a little case study that we'll do just to kind of keep it fresh in our minds as we go along. So let's look at the practice team roles, and every clinic is really different with, the amount of staff and clinical versus admin like team. So the roles are a little bit different like at each clinic. But I guess the main thing to think about is who does what when. And so if I've got, really great admin support, and I always say that I really don't like paperwork, and it's very true. And I also don't like typing and all of these little things in the background. So anything that I'm doing that's admin, my time as a nurse is usually better spent seeing as many patients as I can for these activities that we're talking about. So I think it's a really great time. Look at who's doing what in your team. But reception can do so many things to help support the chronic disease management activities. So anything from, confirming the appointments to checking eligibility. And there's lots of ways that we can do that now as well with some of the software in the background as well. So updating the patient details is really an important part on arrival for any of those appointments, either a care plan or a health check as well. So this is a really great time. Have a look to see what admin is currently doing in these processes, but you'll find there's going to be a few things that we can actually hand over to make it more streamlined. The nurses and health workers, same thing. This will depend on the number of nurses and health workers in your clinic. Some will have dedicated CDM, lists in their like software day to day. So it makes it a bit easier to schedule, health assessments, care plans. Some other clinics might just schedule them on certain days, and, different providers have different requests for, when those CDM activities actually take place. So um, it's really good to have a look at some of these activities that the nurse or health worker might do to support the GP. So if it's, gathering that information for the health check that might be taking place tonight, we're going to talk about the diabetes risk assessment and that health assessment for the 40 to 49s. But also any of the adult assessments we can use as a screening activity for diabetes. So um, the other thing that the nurses will do in the management of diabetes will actually do some of that prep, education for the newly diagnosed and, ongoing management. And that just really helps support the GP in that, follow-up appointment after. So we're going to look at the care plans and then the reviews and the in-between follow-up that might need to happen as well. So the GPs, really, really important role in the diabetes management, and that's from this assessment and planning. And then obviously like the referral process into the programs, allied health specialists and other programs available, but also that review. So I've said it like in almost every CDM training, that review is almost as important as the care plan. So we really want to see our patients more frequently and less time in those appointments. And I found that that has the better attendance rates. I've tested every different way, but I found that that seems to engage the patients more. So the shorter appointments, but more frequently. So 3 months, I usually get asked like the recommended frequency, but 3 months is my preferred for that review period for that reason. So there's so many things we have to do in 12 months, but if we can actually break that down into the smaller activities, it really helps. Which brings us back to our other most important team member that they see, just as often. So the beginning and the end of the appointment. How we keep our patients coming back in for those review appointments or back in for, a health assessment or one of the other activities is actually getting admin to book those appointments at the end of the appointment that we're seeing them for. And what that does, it actually engages the patient more because they're actually being asked by reception, what day and time they prefer, and they're able to commit to coming to that appointment in person, face to face, multiple times. Like they'll usually confirm that with the nurse. The doctor says, I want to see you in 3 months, for your review, and then by the time they get to reception, they're guaranteed to almost come back to that appointment. So it's really important that they do that at reception because they're actually telling them the day, time, and it actually has a really positive effect for them to come back to us. And for those clinics that actually have, allied health and specialist internal services, it might be visiting, a couple times a month, etc. But allied health, in the specialists, they're actually really good to have internal as well because patients love coming back to our clinics. So it's actually really good to have them, as part of that ongoing team and support in-house. So the other thing with the allied health and specialists that we'll kind of mention now and maybe a little bit later is just knowing the out-of-pocket costs when we're putting together, either referral programs for health assessments or care plans. So I found that has one of the biggest impact for attendance. So if we're recommending that, the patient's going to go see, dietitian as an example or podiatrist, but we don't let them know how much that's going to cost. And we just say, yep, ring this number, book your appointment in. And then they find out it's going to be, $100, out of pocket and they can't afford that. Then that's something we should really know, before we're actually putting that plan together. So I like to give it, a couple of options. So a low cost or no cost option, and then a private, option as well, just so the patient can actually make that decision when we're putting the plan or, follow up after a health check for some patients as well. We've got a really great flowchart with the updated allied health referral pathways. So for those that haven't seen this in a little while, I'm going to look on my big screen. The numbers are like really little, but we've got a couple of pathways in. So for those that don't know, these changes happened last year. So they added in that the Aboriginal and Torres Strait Islanders could actually access the 10 under the 715 now. So they didn't actually need to have a chronic condition or care plan in place to be able to access 10 visits. So previously, if you can see on this second line, it was just, five allied health under the 715 and then five under the care plan. So it was really great that it was extended that way. For other patients that have a chronic condition, they can access five. So if it was an Aboriginal and Torres Strait Islander, they can still only access a maximum of 10 under the two. So whether it's under the 715 for the full 10, or if it's five and then five is that option. And then the one that is least used along is the type 2 diabetes group sessions. And I think this is a way to kind of extend our access to allied health for those patients, especially if, cost is an issue. It's a way for us to kind of get subsidized visits. And it's up to 8, so it's an assessment, and then the 7 visits. And it's not every allied health provider under that referral. So for the diabetes GP management plan, they just need a GP management plan in place, not the team care arrangement as well. And that means that for those patients that might not have a full team or enough to do the TCA, we can actually refer under that pathway. So sometimes that's an easier pathway in. It's less daunting for some of our newly diagnosed patients as well that might not, be super keen to go to, I call them the unpopular allied health providers. So the dietitian, diabetes educator, EP, like it's really hard to actually get patients to these providers sometimes. So putting it in a group session is sometimes, a really helpful way to make it less threatening for them to attend. So that flowchart's in our portal for download as well, and we'll talk about that towards the end of the presentation tonight. And the first little case study I've got is just Stuart. So 42-year-old that presents for wound care with the nurse. Stuart's a smoker, overweight, has a history of asthma and hypertension, and the previous billing information. So no health assessments in the billing information. And the last care plan was for asthma over 12 months ago. So reception has done that eligibility check for us and the eligibility for the 721, 723. So is Stuart eligible for a care plan? And the answer is yes. So he has a chronic condition. The last claim was over 12 months ago. So we'll talk about more in the plans when we get to the kind of section after the recall processes. Now, recalls are one of my banes when we used to do a lot of, I used to work in a lot of large practices where we had, 18 GPs. So the recalls seem to be like this never ending mountain of paperwork is what I'm going to call it. So there's lots of ways we can, I guess, try and get patients in for diabetes seems to always be the topic that and condition that clinics are targeting. So I kind of like to look at it in a couple of different ways. I like to target patients that are already coming into your clinic. So like that patient that's coming in for the wound care, if we can see if they're, eligible to come back for an activity, it's a way to kind of get them in as a screening. We'll talk about the health assessment ones, and there's a really good report on Primary Sense that you can pull for the health assessments. So for those that aren't using Primary Sense to identify patients, it's one of the Primary Health Network owned and operated clinical decision support for general practice. So it's a way for you to actually find those patients that we're looking for some of these CQI activities and, early detection activities that we might be looking at doing in the clinic. The reports look really good. You can actually pull, I'll go on to the next one. You can see the one for the diabetes mellitus. So we've got patients with a recent fasting glucose level of over 7 that haven't had a subsequent HbA1c. Patients who may have a diagnosis of diabetes but haven't been coded. patients with a coded diagnosis who may be eligible for a chronic care occasion of service. So there's other ways that we can look at grabbing patients as well through the clinical software. So every clinic's got their own way of doing it. Best practice has a diabetes register as well. This is the reports from diabetes from Primary Sense. So I'll just kind of click through these little sample reports on there. So the patients that may need a clinical review for a diagnosis of diabetes, and they can export to like Excel, the CSV. So however you want to take that data and then action it. Myself, it doesn't matter which way we pull those patients that we're looking at, getting into the clinic for a health assessment or a care plan or a review. I always want to have a quick look at the billing information first. So that's where admin can really help these CQI activities and, take that practice team approach for us to actually, wade through, the 500,000, patients that we may be, looking at targeting. And so the report and, cleansing the data is like really important to make sure we've got, our coded diagnosis in. And it's a really great CQI activity. It was kind of the main ones we used to do for a while before these fancy tools came out. Like cleansing the data was, I guess, one of the first ways we used to do some of those activities in the background. The next appointment process is a really great way to just keep those patients and minimize the recall process. So if we're doing health assessments in the background, a lot of those health assessments that we do can actually come back in 12 months, or a patient may come in for one health assessment and be eligible for another one that we can do in the 12 months after. So an example might be, that we could do a heart health check, and then the patient might be eligible for, either another heart health check in 12 months, or we can get them back in for one of the time-tiered health assessments. So, or the patients that are coming in for Aboriginal and Torres Strait Islander health check, we can get them back in 9 months. So by booking that next appointment, it actually reduces the amount of work we need to do with the recalls, which is music to my ears, because it just means that, there's less, correspondence back and forth. The patient's already booked in. So our recall list that may have been 20 pages long actually dwindles down quite quickly to something more manageable, and it's something that can be handed over to admin. So even those clinics that are using, Hot Docs or some of the other reminder like processes as well, some clinics, when these are up and running in a way that's manageable, sometimes we'll actually turn them off for some of the activities like a review as an example. So there's lots of ways that we can look at, reducing the time intensive nature of what the recall and reminder processes are. And it gives us a chance to actually take a closer look at our data and, pick our activities, more carefully based on, the population we might have and things like that. So deciding how often and how long you need for those different types of appointments can really help admin in the background. So if they know they're booking in a health assessment and it's always 45 minutes with the nurse and 15 minutes with the doctor, then it makes their job easier. So setting up the different appointment types and things in the background can help make those recall processes smoother as well. I've got the care plan one there as well. So as I said, for me, the care plan is just as important as the actual care plan itself, because I really need to do, 20 things with that patient with, diabetes and, at risk of other conditions or may have other conditions as well. So what we really need to do is make sure that we're seeing them for those regular periods. So breaking it into those smaller time every 3 months is actually something that the patient, gives positive feedback on as well, that they're just coming in for those shorter appointments every 3 to 6 months, depending on the patient. I've attached the little step-by-step for the health assessment reports in Primary Sense as well. So for those that are actually looking at doing some of those health promotion activities. And by that, we usually end up doing a health assessment. So it's those prevention and early detection activities. And any of those adult health assessments, they might not be eligible for a 40 to 49 at risk of diabetes assessment, but we can actually maybe do one of the other assessments. And we can still do the screening tool and other activities as part of that. So um, I've got the little steps for those reports, but it's worth kind of looking at, the demographics of your patients and seeing, where's the best, place to start. So if I've got more patients in, that 40 age group, then I'm really going to be targeting those patients. So the case study I've got for this little section is, so while waiting for the GP to review Stuart's wound, the nurse mentions to Stuart that he may be eligible for a type 2 diabetes risk evaluation. And so what does the nurse need to do to confirm that Stuart's actually eligible for one of those health assessments? So at risk of type 2 diabetes. And so what we need to do is make sure that he falls into that age group of 40 to 49. We need to actually complete that OSRIS tool within 3 months of completing that health assessment. So we need to do it before we actually do the health check. And the patient needs to be high risk. Now, if we've got time, I'll show you the OSRISK, and everyone thinks it's really hard to get a high risk, but it is actually very easy, especially once you hit a certain age. We kind of seem to fall into the at-risk category for everything. So if we've got time, we'll run through that as a screening tool as well. So prevention and early detection, for me, it's a bit of a balancing act. We need to screen patients and get them in for these preventative activities, so we aren't actually getting them diagnosed with the condition. So it's a bit of a balancing act. Yes, we've got to manage our patients with diabetes really well, but yes, we also need to target our patients that are at risk and high risk of developing diabetes, and getting them in for a health assessment is the best way to do it usually. So we're actually covering our time that we need to actually do like a full assessment, and then we can get the patients into a lifestyle modification program. So there's a couple that are available, and I'll show you through health pathways as well after we finish this little section of slides. So there's 3 different types of health checks. I'm not going to go into depth too much. We're mainly going to talk about the time-tiered and 40 to 49 health assessment tonight, just because it lines up with the diabetes topic. We've also got a little flow chart with the updated changes of what's happened in the health assessments in this last 12 months. So a couple of things that you might not be aware of in the little explanatory notes now in the 715, it triggers the 10 allied health visits, but also with the 715, we can actually also do a heart health check for those patients in the same 12 months, and previously we weren't able to. And the other big change was that patients can have more than one time-tiered health assessment in that 12 months. So if I've got a chance, I'll go into the explanatory notes and show you in Medicare at the end. But if we don't, I've got the links to those particular explanatory notes so you can have a closer look afterwards as well. Okay, so it's something to just keep in mind, and that can help, plan our care and, preventative activities or health promotion activities that we might be doing at the clinic level over 12 months. So many activities that we need to kind of screen for, but as we said, once we hit a certain age group, we're at risk of so many other conditions as well. So based on our patient's age and, other risk factors that we identify, usually we have a list of, tests and screening that they might need to come back for over the next, few months. So same thing, we don't need to do everything today as part of a health assessment, and flagging these activities is the main part of that health assessment. So we actually just want to identify what they're actually due for. So it's our big to-do list in a health assessment, and then we kind of tick off those things one by one as they come back through over the next few months. So the Osris tool has had a little bit of a refresh if someone hasn't seen it in a little while. For anyone that's done training with us before, I really love the hard copy Osris. You can order them for free. I've got the link down the bottom there. I found it really helpful to do this with the patient, as in I know we can do it on, a lot of the software now, and I still record it that way for our data, but I still prefer the patient to actually go through each of these questions with me, because they actually have this moment of, it's actually, I'm really high risk, and they, just didn't seem to realize. So I think it's really important process. We know they're at risk, but a lot of the times they don't know they're at risk. And then there's some great resources available via the practice support website. I'm half Greek, so I've got the Greek one up there for us. Don't worry, I'm not going to read it. Um, but, it's available in all other like languages now, which is, really great to see as well. So, depending on your patient demographics, you may, like to have some of those available as well. But the Osris tool is something that I usually have hard copies on a clipboard ready to, do these activities with pretty much every second patient. So um, something to just get prepared and, have ordered in the clinic, or the downloadable versions, interactive as well, that are also available, just to help engage the patient in that process. So a little case study. So we've got the nurse performing the Osris tool with Stuart, and he's got a score of 24. So does a score of 24 on the Osris make Stuart eligible for the type 2 diabetes risk evaluation health assessment? And the answer is yes. So a score of 12 or more is considered high risk. And I usually, if you haven't done the Osris with a patient before, I like to start with the score. And it's mainly to explain to them that we're looking for a score of 12 or more. And then for anyone that hasn't done the Osris on themselves, it's the most depressing screening tool you can ever do. A couple questions in, people are looking at age, gender, and, a lot of the points come from those non-modifiable risk factors. So, yeah, it's a really helpful screening tool to use with our patients. So any health assessment or screening activity, we're really looking at risk factors with patients, and the whole idea is for us to recognise the risk factors that they have. So the non-modifiable risk factors, and then the modifiable risk factors, we want to be able to recognise and get the patients into a lifestyle modification program to reduce their risk of getting any of these chronic conditions that we're screening for. So diabetes being number one on that list. There's a couple of programs that are available. We've got some slides on the My Health for Life. So for those that haven't seen it, I'll open it up in Health Pathways as well. So it's a Queensland-wide health coaching program, and it's for those at high risk. So it's not available for patients that are diagnosed with diabetes. So when we're doing those health assessments and we flag that the patients may be eligible and actually want to and are ready for change, then this is one of the programs that's available as well. So their phone coaching or like group sessions covers everything from nutrition to physical activity, smoking cessation, stress, and a whole heap of other things. So if you haven't been on the website, they've done a little bit of an update as well. There's writable PDF that you can download as well. There's lots of brochures, other health professional like information as well. There's lots of referral options. There's little health checks so people can kind of look at that referral process themselves as well. And then that's a really good little flow chart just to keep handy as well. So it'd be something that I'd usually probably print and laminate hard copy that I could find quickly, or just, tag one of those pages and bookmark it so I could actually find what I need. So there's some of our prevention and early detection activities. We're going to jump into the care plans now. So the diabetes care plans, for those that haven't seen the updated guidelines as well, I put a link there for the updated guidelines, updated in 2024. So if you haven't had a chance to have a look, the link's there, and you can also find it through Health Pathways as well. But I guess one of the big questions that I always get, and I used to get referred a lot straight from the GP, the newly diagnosed like diabetic. So, it's a lot for patients to receive a new diagnosis. So when we're putting together that care plan for diabetes, especially for those patients that are newly diagnosed, there's a couple different ways we can do it, and it obviously like depends on the patient, but my preferred way is not to kind of bombard everything on that one day, as in, 10 different referrals going out and, things like that. So it's obviously going to depend on the patient, but remember, we're after the patients to come back and engage with us regularly. So we're looking after this patient for the next however many years. That they're going to be with us. So it's a long-term plan. So we want them to come in for the plan, but yes, we also want them to come back and leave not going, I'm never going back there again because, I was there forever, and, they might not be ready for some of those change in lifestyle that we're, wanting them to do right now. So I like to just start small and kind of go from there. So if they're ready, obviously we'll, do some of the lifestyle referrals out, but I like to start with some of those ones that we definitely need to have, ticked off as part of that diabetes cycle of care. So I really want to have, make sure we've got our optometrist check done. Want to make sure I've got, podiatrist visit as well. So if we kind of get started, get the plan in place, get our to-do list, everything we need to get done in that 12 months, I will bring up lifestyle modifications and goal setting in that care plan. But if the patient's not ready to set some of those goals around lifestyle, then we'll kind of start ticking away at some of the other things on our to-do list. So it doesn't always have to be that day that we, I guess, get to the finish line. What observations? So a lot of the times they may have other conditions as well, but usually a lot of our adults were doing height, weight, BMI, waist, blood pressure, heart rate, blood glucose level, and then obviously depending on their age and other conditions, we may also be doing some other testing. Other clinics have, point of care available as well. So it just depends on your clinic. So we usually do annual ECG for patients with chronic conditions as well, and that will depend on your clinic and GP's preference. I've got a couple slides on the CDM item numbers. I'm not going to go into depth with those, except mentioning the time-tiered health assessments. I've got the links there to the updates and the numbers that happened last year. So if you haven't had a look at the explanatory notes, I'd just maybe jump in there to have a look. We've got a lot of other numbers that we can do as part of our screening and follow-up activities as well. So I've got our ECGs, spirometry, obviously depending on the patient's other conditions, the telehealth support for the nurse or health worker, for the specialist, if that's happening in your clinic as well. And then I've got our follow-up numbers. So once if it's a patient with the 715, so there's different ways that we can follow up, not just face-to-face anymore. And for me, this was one of the best things that came out of COVID. So we don't have to have the patient there with us to be able to follow up. So there's a video conference option, but the most popular one has been the phone. So that 93202, that's follow up after a 715. And then for those patients that have a plan in place, we've actually got the 10997 for face-to-face. There's still a video conference catch-up one, but again, the most popular is the phone, so the 93203. So it's worth just reviewing those numbers for our more complex patients. I also had the case conference numbers on the previous slides as well. So I've just got our allied health pathway there, just for a quick look before I give you the question. So we've got Stuart back. So a few years have passed and Stuart's now confirmed with a diagnosis of type 2 diabetes. He attends the clinic for his first care plan. He has concerns about his foot care and mentions that he's interested in having support to lose weight. So how many sessions can Stuart access under the allied health pathway? So once he's got his care plan in place for diabetes, so GPMP plus or minus the TCA. So under that flow chart that we had, so it's 5 individual services. So the 5 under the care plan. He can also access the group allied health sessions as well for diabetes educator, dietitian, or the exercise physiologist. And if Stuart identified as Aboriginal and Torres Strait Islander, he could also access 5 under a health assessment as well. So depending on your patient, they can access up to 18 visits that way. And then the next one I've got is, so you and Stuart discuss his follow-up appointment for the GPMP review. And he states he'll book his next appointment with reception. So, when would be the earliest recommended review? The earliest time we can do that is within 3 months. So that's if it's not, exceptional circumstances. And you'll find that definition of exceptional circumstances just in the first explanatory note of the CDM numbers. And I've got it in the links as well. So for those that haven't accessed health pathways before, I've got the QR code there, but you can easily just jump on the Brisbane North website and search for health pathways. It's amazing for any condition that we're looking after, referral pathways, guidelines, screening tools, everything that you would do on Google, you do with inside the health pathways. So I use a lot. I've traveled everywhere working, within Australia as well. And so it's actually really helpful for those pathways for to be able to find that wherever I'm working. So each PHN's got dedicated pathways for your area. And so if you're looking for services, and I'll bring up a couple of pages for us to have a look at as well, just so you can see that. So I'm just going to bring up the health pathways, and then I'll hand over to Julio. So I've already got a couple pages open. So I've got the screening and diagnosis of diabetes in adults. So over on the left, you can see all of my different pathways under diabetes. And for those that haven't used it before, there'll usually be like a bit of a background up the top, and then it will go through assessment, and then management, and then there's also other information. So a lot of the health professional information and links to other documents are in there as well. So you shouldn't have to search too far to find what you need. So that's for the screening and diagnosis. And then in the management pathway, so management of type 2 diabetes, it actually kind of just goes through everything we just looked at. So it's got screening tools there. It's got, advice on those lifestyle risk factors. And then this lifestyle modification program, I've got it open separately. So it's actually got your programs that are available that you might not have heard of before, or, heard of it but didn't know how to refer in. So it's got like Work It Out, the My Health for Life is there as well. There's a Living Well multicultural program as well. Quitline, self-management of chronic conditions as well. So another telephone support number. So if you haven't used health pathways before, then it's really great to just jump in and have a look. Once you're in, you'll just kind of keep looking up things. So it's one of those pages to just have bookmarked in the background as well. So I'm going to hand over to Julio. He's just going to go through a couple of things on the practice support website.
Thank you, Jane, for the amazing information. And now to everyone's favorite topic, continuous quality improvement. In the last 6 months, you may have noticed that Brisbane North PHN has come up with a little bit of bigger initiatives. We have the multicultural health and the cancer screening projects that have been successful so far. And following along this same process, we now have access to this new CQI focus in diabetes. So if you allow me, Jane, I'm going to share my screen just to guide everyone through what the website looks like and how to arrive to this page. So, oops. So here's the page, although arguably I should start from scratch. Sorry if that I'm not looking at you guys, I just have a different screen here. So this is what the main page looks like. You just only have to go diabetes, and the first result that pops up, although it's this one, And this is the page that we are coming to. So if you've done the previous initiatives, we have a structured way of doing it. We have a document here that guides you through the process. So I'm going to talk a little bit more about how the expression of interest works, but I would first like to focus on what the CQI project looks like. So we were thinking on how to divide this project, and we come up with 3 focus areas within this CQI. So we have improving identification and prevention of diabetes. We have a section on enhancing data quality, and we have a section on improving diabetes care and outcomes. So in this document, as you can see, we've come up together each one, and you can implement in your practice, but also you're always welcome to use and do any activity that you think it's going to be best for your practice, right? So in this document, there's a bunch of resources that might be useful to you depending on where you want to focus. You can choose to focus on all 3 of them. You can choose to focus on one particular side. You could, for example, just do enhanced data quality, right? So if you have not participated with us in the past, how this process works is really simple. So basically, what you guys have to do is to complete part 1, which is the expression of interest that I'll show you. This is also available here in the practice support website. So you would go here in diabetes CQI plan. So this is what the expression of interest look like. It is a very simple document that you fill with some data, and you have to give us part 1. And this is where you're going to put what are the activities that you want to do, and what goals that you want to accomplish, and things like that, right? And then step 2 of the process, just coming back to here, step 2 of the process, we will receive your expression of interest and analyze it, and then let you know that you've been selected to participate in this program. So after receiving that confirmation from Brisbane North PHN, then you can start working on your proposed activities, reach out to your quality improvement and development engagement officers. They're going to be incredibly helpful to guide you through this process. You can also choose to do it by yourself. All the document and all the support that you need is in our website, right? So after going through the PDSA cycles and getting to know how your activity went, then we fill part 2 of the same expression of interest, right? This part 2 is more of a reflection on the activities. How did it go? Was there any adoption? Was there any adapt? Was there any abandoned activities? Why? And it kind of just guides you through some, just reflective questions on how the activity went. And at the end, what you will have as an incentive is what we've talking about a little bit as the portal for CDM Plus. If you did the activities in the past of multicultural health and cancer screening, those were paid activities. This will not be a paid activity, but you still have the incentive. So in this case, you will have to do at least 2 activities. After doing the activities, fill in the paperwork, you will gain access to the portal. So that is what this new CQI focus looks like. We really want to support you. So if you have any questions, please reach out to your engagement officers, reach out to practice support or myself, and we will be able to guide you through the process. I'm just gonna stop sharing my screen so we can go back to the slide deck. I just wanna introduce you to some of these amazing people that are gonna be able to guide you through this process. So this is just a summary of the process of how it works. And then in our next slide, we have the team. So you are probably very familiar with these people, with these amazing human beings. They have a bunch of experience. Reach out to them, and we will be able to come up with a plan together to improve diabetes care in our region, right? And now, because we understand that CQI is something that you cannot always have options, right? So we've seen that this type of approach is working. So we have now planned different focus areas throughout the year. So we have this current activity in diabetes. We are closing up the 2 previous ones that I've mentioned, but then we will have a focus in my Medicare chronic condition management, which I think a lot of people are going to be really interested in that one. And then in October, to the end of the year, we're going to have a second focus on cancer screening, particularly with a new lung cancer screening program that is going live July 1st. So these are this type of projects. I hope that they are really useful. We are always open for feedback. So if you have any feedback for us, let us know, and we will continue to improve this whole process as you improve your practices. So going a little bit on the portal, what does a portal mean? What is a portal? What benefits does it come for the portal? I think Jane can walk us through what that entails.
Yeah. Thanks, Julio. So everyone can see that screen again now. So I think it's a great CQR activity that they've got like lined up for you to do that. If you need a hand, we've got some set up in our like portal as well. So to get access to the portal, you need to do the other activity first. So we have like a health promotion program, which is some, really great activities. We've got our own PDSA like cycle and planner that you can use as a writable resource in your like clinics. And we've just got an example of one there for diabetes. You also will get access to all of our online modules, so our introduction online modules, but also advanced. So we've got mental health and some, great digital resources there as well. We've just launched an immunisation and COVID update as well. So there's modules being released all the time. You'll have access to all of our templates and tech shortcuts and our Watch and Learn series. So for those that are using best practice, that's available there for you, and medical directors launching very shortly as well. So there's, content and pretty much everything that you're going to need with these upcoming changes for Medicare. So any time that there's a change with Medicare, our resources will update to reflect that. So, our chronic disease manual, there's so many things, all of those flow charts that we looked at before with our GP mental health flow chart, as well as the health assessments. We've got all of our, billing sheets, and the digital versions of, all of our really great resources. So you'll have access to all of that inside that portal as well. The billing sheets are really helpful when you're trying to figure out what items and things to look at as well. And then that health promotion plan that comes as print versions and, writable as well. So there's some really great resources that you'll be able to use outside of the CQI activities for your, chronic disease management as well. I've just got a couple questions in medical director or one of the other like clinical software. Recording. So the allied health and specialists, because I can't remember anything and, we've got too many providers to kind of keep track of. I found it easiest to keep track of, how much it was out of pocket or whether that provider just offered individual group sessions, just so I could actually show the patient. I used to just put the date there so I knew if I hadn't called in a little while, like within that 12 months, that I just ring to just double check that the pricing hadn't changed. So that's how I used to do it. Some clinics will just have a list of, those different providers and, local programs that you might have running in your area. And then the other question that I had, I'm just going to bring the slide back up because I won't need it.
For that, is it okay if I intervene?
Yeah.
I don't know if also this question might have been referring to the group sessions of the My Health for Life program. But in the case you were, Sarah, if you were referring to the My Health for Life program, how it works is that the patient has to do what we call a health check, right? And this health check is basically a survey with some questions. And once the patient is deemed eligible for the to go into the program, the participant itself will receive a phone call from the customer service team at the My Health for Life program, and that phone call is what they're gonna tell them which group is available and where. So I hope that answered the question. but yeah, in general, is once the patient is eligible, the patient will receive a phone call, and then the patient can choose either to go to the group sessions, which are face-to-face, or there's also the option for a phone consultation. Well, you go through the 6 sessions via phone consultation. So hope that answered the questions here. If it was referring to the My Health for Life program, either way, remember that we are recording this, and we are also going to be sending any answers through to you along with the resources that Jane has mentioned in the next couple of weeks. So keep posted, and you'll receive all the information.
Thanks, Julia. And the last question was just on some of the Medicare items. So I think it was Audrey mentioned about the annual cycle of care. And like, so once those item numbers stopped, I know it became hard for a lot of like clinics to kind of schedule without that annual cycle of care number. But, you know, that kind of merged into the quality improvement PIP. So it didn't disappear totally. It just kind of merged into a different incentive. And at the end of the day, we still have the care plan and the reviews until they change or whatever's going to, you know, come in these changes. But we've got those regular review appointments that we can do. With the ECG, I know that when those changes came in a few years ago, a lot of GPs weren't doing the ECGs. But if you just look at the criteria, I might even just bring it up to have a look. I actually created a text shortcut that actually has that new criteria there because obviously I can't remember anything. So I want to have that in my text shortcut. So, you know, we can obviously still bill an ECG, but it's only in certain circumstances. So if we're billing it as part of something that falls under that criteria, then we can. Same with the ABI. So the little criteria, because I know you said like some of them got rejected or got, you know, triggered in like an audit when that, you know, happened. It just depends on when it's actually delivered. So a lot of them will say it can't be done on the same day as a health assessment, as an example. Not this one, like the ABIs, I know were one of those item numbers that kind of you can't do. So there's certain conditions for some of those follow-up numbers. So the easiest thing that I've found is to have a lot of, because I can't remember anything, I want everything text shortcut. So, you know, if I'm doing a ECG, if I'm doing a COPD screening, if I'm doing any of these activities, I want to make sure that I've actually got a text shortcut set up. So, you know, I don't have to remember anything. But I know that I've got a text shortcut to match, you know, that particular activity. So, you know, as long as I've got my shortcut set up like that, then, you know, it just makes it easier for me to fill in the gaps. So it's less time. And, you know, if there's an audit, they can see if I've actually met that criteria in the progress
Jane,
note.
can I
So,
interrupt and ask,
yeah.
you in your portal have got a lot of text shortcuts sort of set up for people to access and also care plan templates to import into medical director and best practice?
So all of our text shortcuts, not only our chronic disease management ones, you also get access to the health promotion ones. So we've got all of our chronic disease risk, like chronic kidney risk screening, COPD screening. So all of those screening activities are all there for text shortcuts. So care plans, health assessments, plus all the health promotion activities that we would normally do as well. So all of the templates that we have, whether it's your care plan ones to kind of bring in. I know a lot of people end up doing a lot of typing. If you're not like me, I don't want to type. So we actually set up a lot of the system templates in the background and the disease templates. So as an example, I'm not spending my time typing problems. I do the free type of the patient goals, but I'm not typing every single task. So if you haven't got these set up and you want access to our templates so you can just import them in, then complete that CQI activity because you'll be able to import those conditions. And then when I'm actually putting a care plan together, I'm just popping those details in. So I'm not typing all of this, but there's people that are spending time, you know, kind of typing all these in. What I'm doing is pulling in the information and then I'm deleting what's not relevant and kind of editing those out. So you can actually, you know, delete anything that's not relevant for your patient. So you can see the different ways we've got ours set up. I've got a lot of test ones in here, but as an example, we've broken ours into some of the really basic conditions, and then we've got prevention and early detection for our patients as well, which covers our lifestyle, immunisations and cancer screening. So every single patient, regardless of their chronic condition, will have those three things as part of their care. So, it just ends up being less time that I'm looking at the computer and more time that I'm spending with the patient, because I don't know about anyone else, but I don't want to be doing, care plan paperwork, health assessment paperwork after everyone's gone home. So I want to be able to allocate enough time so I've got that done. So our home medicine review templates, all of our health assessment care plan templates are there as well. We've also got case conference templates available for those clinics that are up and running with those. And coming in the next month is anything to do with integrated team care. So we've got some, great templates coming that way as well. But yeah, anything that's not in there, request it, and it usually ends up in there, pretty soon. So we've got, dedicated trainers, like always kind of creating and putting new content in. So if you've got a template that you don't like, the GPs will usually love the mental health one. We've got an updated mental health template that you can bring in as well, for BP, medical director and communicare, that you can just kind of pull in. It's got a lot of those customized fields that just makes your job a little bit easier to complete the mental health treatment plan. And if you want to know how to edit and kind of customize your own templates, then you can actually watch the Watch and Learn series. And we've also got step-by-step instructions on how to bring any of those in with, screenshots and things as well. So I'm just going to come back the slides. I couldn't see any more questions in there, but that was kind of the last of those slides. So I just wanted to say thanks for having us tonight. Thanks to the PHN for kind of funding this activity and some of the other webinars coming up that we'll be doing. So if you haven't registered yet, we've got the Navigating Chronic Condition Management and My Medicare updates coming 17th of June. And then there's a part 2 to that one as well, so implementing chronic condition management. So I'll give you a sec if you wanted to scan that code as well, but I know that the PHN are already sending out correspondence and things for these webinars as well.
And we would like to invite the participants to attend both of the webinars. They are linked one to another. So ideally, if you can attend both, that would be great. Otherwise, that session will also be recorded and distributed at a later time. And just before we finish, Jane, thank you so much on behalf of the PHN. You're always a wonderful speaker. And thank you to all the people who've attended and taken some time out of your busy nights. So thank you for attending tonight's session. And just a clarifying comment just before we finish the session.
Yeah.
The My Health for Life program is for people who are at risk of developing chronic condition. So once the patient is diagnosed with either diabetes, hypertension, or chronic disease, they are not eligible. But if you have any doubts regarding that program, it is a free program. You just reach out to us and we'll be happy to provide more information about that amazing program, which apparently a lot of people thought that it stopped. But no, we're still going stronger than ever. So again, thank you so much, everyone. Thank you, Jane, for coming along, and thank you for all the people at the background that made this webinar possible. So if anyone wants to comment anything, please do. Otherwise, thank you.
Thanks, Julio.
Thank you. We'll be there's a survey coming up just as we close this session. Please answer the survey. This is the way that we are able to give you what you want. This is the way that you can actually make your voice heard. So please answer the survey. It's just going to take a couple of minutes. If you want as a certificate of attendance, you kind of have to answer the survey just because that's the only way we can get your details. So again, thank you and have a wonderful night, everyone.